All right, hello everyone. Welcome to our debate over restraint and seclusion for SPCE 619. My name is Josh. Others that will be speaking today are Ariel, Covel, Andrea, Lindsay, and Kelly. First up, we're going to have Kelly to introduce our debate topic.
The term restraint is defined as a restriction of the freedom of movement or normal access of a person to his or her own body using a mechanical device or physical hold by a staff person. Seclusion is the involuntary isolation of a person to an area or a separate room where the person is physically prevented from leaving. The debate on restraint and seclusion has been argued for over 200 years, dating back to 1793. When a French physician unchained insane women in a Parisian asylum who had been restrained, some for several decades. This sparked debate about moral treatment of patients, and it led to the Quaker York Retreat in 1796, which proposed moral treatment without restraint. The debate continued in America, and the superintendents of the American asylums debated using restraints and rooms for seclusion at their annual meetings. As of debating the topic, it was concluded that they should be used as a last resort with properly trained staff, supervision to prevent harm. Recent publicity about harm and deaths while using restraints has reawakened this debate, though. Why is this relevant to behavior analysts? There's a pie chart. This shows the use of restraints and seclusion in schools in Connecticut, so it's not an exact representation of all of the United States, but it shows that the vast majority of restraints and seclusion are used with people with autism, and after that, mostly with people with emotional disturbances. And just to keep in mind that use of restraints and seclusion with children, school children. On the next figure, we see a US map that shows the frequency of restraints used for students with disabilities. It shows a lot of areas that have anywhere between 10 and 80 restraints per 100 students with disabilities. It's very inconsistent. Is 80 restraints per 100 people really necessary, and is it ethical? Very few areas are listed as having 0 restraints per 100 people. As behavior analysts, we have an ethical code to adhere to. We must use effective treatments, but we must also do no harm and treat our clients with dignity as we would want to be treated. So we've outlined 3 main areas of concern when debating the ethical use of restraints and seclusion, which are safety, psychological and therapeutic effects, and problem behavior reduction. We hope that the information we provide helps to make more informed decisions which are ethical and whether they are necessary.
All right, our next speaker is going to be Ariel speaking for restraints and seclusion in the terms of safety.
When done properly, the use of restraints and seclusion can be implemented to ensure the safety of not only the clients, but others involved. And the others involved can be anyone in that space at the time of the incident. Managing violent behaviors can be challenging, especially when trying to make sure no harm is done. And doing no harm is one of the ethical principles for a behavior analyst. There should be no harm done to clients or staff members. And as I stated earlier, anyone in that space at the time should be kept safe as well. There was a study conducted in 2010 by Kasky Valcoma, and this study found reasons for restraint and seclusion included actual violence, and actual violence could be physically hurting someone or physically hurting yourself, threatening violence, and this could be saying you're going to hurt someone or saying you're going to do something to yourself, damaging property, and this could be throwing items, flipping over desks, or anything that could potentially break something in the classroom or the workspace, and the others were aggression and dangerousness. Those who engage in such behaviors could be restrained or secluded to ensure no further damage is done. And removing a client from a learning or a workspace could keep them from learning or could keep them from completing a task. But if others are involved in that situation, it could distract them and it could possibly harm them. So removing them for a little while is better than having someone get hurt and having someone hindered from learning. There are other effective methods to alter dangerous behaviors, but with proper training, restraint or seclusion can be used when there are no other successful methods that are working. In 2014, there was a study conducted by Marino Cote, and the participants stated they understood restrictive measures were done for safety reasons. And the participants also said that the restraints and seclusion calmed them down. And as I stated earlier, it could keep others from being distracted, and it could keep others from harm's way if you just remove them for a little while and then bring them back into the situation. So the use of restraints and seclusion should be applied strictly to maintain the safety of persons involved in harmful situations when other methods are not effective.
Next to speak will be Covell for safety against seclusion and restraints.
So as behavior therapists, the well-being and safety of our clients comes first. And it's important to use least restrictive procedures in the treatments that are in place. And this is stated in Compliance Code 4.09. Several studies and reports have recognized that the use of seclusion and restraints is often detrimental consequences, such as injury or death to the staff, the client, or others in the room. Some headlines and reports that I have read pertaining to this topic include an incident where a 9-year-old boy was restrained by his teacher in a timeout room and he was the victim of asphyxiation. A 7-year-old girl died after staff members restrained her face down on the ground in prone position for several hours. And a 6th grader had his leg broken by his teacher who was attempting to restrain him. And these were all found in the Government Accountability Office. And these are a few of the hundreds of incidents and headlines involved when using seclusion and restraints by trained staff members. And here's a short video showing 2 separate incidents of students that were restrained or secluded. So in the video, you can see the marks on the boy's arm after being restrained for 3 hours, which illustrates that even if staff members are trained in safety management, it's not always enough to prevent injury or death, unfortunately. Even though there have been so many incidents reported, the use of seclusion and restraints is not federally regulated in the school system. According to the National Disability Rights Network, 41% of states have no guidelines, policies, or law that oversee the use of restraints and seclusions in the school system. At LaBelle et al. 2012. It's also a huge misconception to assume that restraints and seclusion are used more so with older students, when 53% of incidents are kids that are 6 to 10 years old. According to Nishimura, 2013, the most likely to be restrained and secluded are those with attention deficit disorder and autism spectrum disorder, even if they aren't physically aggressive. Young children who have been restrained in the prone position, which is actually the most dangerous method used, have been the victims of asphyxiation. Using restraints and seclusion on persons with intellectual and behavioral disorders are not effective behavior management practices. Compliance Code 2.09 states that clients have the right to effective treatment, having both short and long-term benefits to clients and society. Using restraints and seclusion goes against this code, since it could cause the clients being treated to be apprehensive to treatment in the future and for them to become more angry. Even though many schools still continue to use restraints and seclusions on students with disabilities, little is known as to how effective they actually are.
Next, I will be speaking on the psychological and therapeutic effects for seclusion and restraint. So some researchers by the name of Favell, McGimsey, and Jones in 1978 had done a study where seclusion and restraint was part of an aversive or non-aversive package. And they found that self-injurious behavior was one of the benefits of using this package through their research. They also found two other interesting findings: an increase in the quality of life due to reduction in bodily harm, and social or leisure activity increases. So an example of an increase in quality of life might be time in the hospital, for instance, would take a student out of the classroom for a duration, or maybe if they were on the cusp of learning something new during therapy, that may be undone for the duration that they might have had to go into the hospital or recover from an injury, if it's a self-injurious behavior or bodily harm has done something such as broken their arm or had given themselves a concussion. So in these types of situations, I think it would be very helpful to use restraint and seclusion as found in the study. Another instance might be medication. Some kids have been reported to be so medicated that they might fall asleep a lot during school or in class, which can kind of reduce their personality in a way. They're not the kid that some of their family might know or before they had been on that medication. Another negative effect of being medicated might be drooling all over yourself or inability to help drooling. That's another type of story that I've heard people talk about. An example of a social or leisure activity increase might be time spent in problem behaviors can reduce the opportunity for learning. And with restraint and seclusion, you can get a quicker end to problem behavior and learn more self-help techniques in this way, that you would be more likely to come back from that seclusion timeout back to class to increase your learning opportunities. This also helps decrease distractions from students having problem behavior within the classroom and distracting other students' ability for the learning opportunities. And in addition, the paraprofessionals or aides or the teacher being distracted by having to help with this or attempting to go on with the lesson while others might be trying to pay attention to this this problem behavior. So restraint might reduce it, and you could also remove the student from the situation into a seclusion or a restraint type of situation to reduce distractions, to increase social or leisure activities. Things that we would want to look at as a BCBA for this is 2.09 A, C, and D. So the more data and research to make sure that the efficability, the efficacious way that we use the restraint and seclusion in behavior plans or methodologies training and risks, the staff that would need to be trained, or what types of risk you could incur from using these seclusion and restraints. And then intervention, efficacy, and treatment integrity. So making sure that the BCBA is monitoring the treatment integrity and the application of these procedures effectively when used on students. Some positive therapeutic benefits that have been found by Day in 2002 with a meta-analysis are increased coping skills through verbal expression, increased self-control, and a safe way to release stress through anger. So an instance of increasing coping skills with verbal expression is with a replacement behavior. So you could see this in a simple sort of command that you would teach a child or a new client. They might have problem behavior in order to get access to something that they want. So the replacement behavior that is demand would start being able to be more functional and take over the spot where the aggression might have been, as long as with the use of seclusion and restraints that would reduce the problem behavior, and then the replacement behavior has more opportunity to contact that reinforcer to be increased. Now, using MANS was a simple instance where you would use seclusion and restraint for more severe things like self-injurious behavior. But that example kind of illustrates an easy way for most individuals to understand, because most people have experience with replacement behaviors and MANS, and increasing those and reducing the problem behavior as a type of example that could be quickly brought to your mind. So in increases in self-control, there are situations that people don't necessarily want to be in, and it's not necessarily a bad thing if punishment occurs, because behaviorally, punishment just means that it reduces a behavior. It doesn't mean that a negative connotation outside of ABA. The negative connotation is more along the lines of you're whipping someone or you're shocking people, which that's also inside ABA therapy in the past, but that's no longer part of it. But those types of things that the news outlets have kind of painted punishment as, and then you think of outside of ABA, has kind of brought punishment into a negative light. But punishment can be something as simple as you wanting to leave a room just because there are loud noises and you just need a minute to yourself. A safe way to release stress through anger could be using an example of a neurotypical child versus a child with autism spectrum disorder. So in a neurotypical child, normally you would be able to learn a situation somewhat easily, and then you might know that replacement behavior of just leaving the room if there are loud noises, going back to the unpleasantness from earlier. An individual may not be able to process that or quickly learn that, and we might have to, depending on the aggressiveness or dangerousness of their behaviors, use a restraint or a seclusion in order to more quickly increase their quality of life using those types of procedures in order to help get them more opportunities for the replacement behavior of expression through anger, or giving them a way to release that anger, such as independently walking to the seclusion room, and not necessarily the negatively painted picture of someone dragging a child into a room and locking them in. That is not necessarily how it works. And next, we will have Andrea talking about psychological and therapeutic effects against seclusion and restraints.
The use of restraints and seclusion as approaches for aggressive or self-injurious behaviors can have little or no therapeutic effects on individuals these methods are being implemented on. Fisher in 1994 found that restraints and seclusion are effective at preventing incidents of self-harm, harm to others, and property damage. However, there is very little evidence that these methods yield to long-term reduction of behaviors.
The use of restraints and seclusions have high risk of physical and psychological damage to both the individual and the caregiver or staff. Manu Cote in 2014 conducted a study that examined the perspectives of both the patients who experienced the use of restraints and seclusion, as well as the staff that implemented these interventions. The patients in these studies revealed numerous alternative methods they would have been more responsive to, such as taking a walk, talking to the staff, or writing about it. These alternatives are less harmful to the individuals. These methods, specifically seclusion, can also interfere with an individual's productive therapy and learning environment. When an individual is removed, they lose the opportunities provided in that therapy. For example, if an individual is in a group instruction, say for math class, and is restrained or removed for the disruptive behavior, that individual loses the learning activity for both appropriate behavior as well as what is being taught in the group. This removal could also become a negative reinforcer for the individual that no longer wish to participate in their therapeutic or learning environment. Thus, the individual's behavior may actually increase to get out of whatever they don't want to do, basically. Overall, the use of restraints and seclusions are not therapeutic interventions, but more of a preventative measures to ensure safety. Where safety is important and should certainly be upheld, the detriment to the individual's mental health and damage to their therapeutic environment is something that should be considered.
Next, we have Lindsay with problem behavior reduction for seclusion and restraint.
Thank you. So as BCBAs, we must be able to control problem behavior. It's one of our main goals is to, so for example, being able to reduce elopement, being able to reduce aggression, all of these make up skills that we and behavior excesses that we need to decrease. And in my personal experience, we've been able to successfully use a seclusion-like event where we are with the child but in a separate room and we're with them all the way. And with that, it's been proven that restraint and seclusion are very useful in preventing elopement and injury. And this is proven by this is supported through Merino Cote, where they said, where to contrast Andrea, it's Merino Cote stated also that restraint and seclusion help calm down aggressive patients, as well as they realized that the restraint was for their own benefit. It wasn't for any aversive method whatsoever. So, and the ethics in question is using the least force necessary. And from what I know from my clinic that I work at, as well as with what Merino Cote said, as long as we use the least restrictive force necessary, and as long as we're able to use these methods in a safe way, they are able to, overall, they reduce behaviors and they keep the child safe, and they keep the therapist safe from any behaviors towards them.
Next, we have problem behavior reduction, and Kelly will be speaking against seclusion and restraint.
So restraints and seclusion are not ideal for problem behavior reduction, and they should be used as a last resort. And ethical compliance codes have been mentioned thus far, but they're worth mentioning again. So the first one is 2.09. Behavior analysts have a responsibility to their clients, and our clients have a right to effective evidence-based treatment. And restraints and seclusion do have some support, some research behind them that they can be effective treatments, but that doesn't mean that they generalize to all populations and all problem behaviors. But the more relevant ethical and compliance codes are 4.0, that behavior analysts are responsible for all aspects of a client's behavior change program. Specifically 4.08, which is that behavior analysts consider reinforcement over punishment whenever possible. And 4.09, that we use the least restrictive procedures that produce results. This is key because we must consider all ethical codes when choosing an intervention. We can't just pick and choose. So saying that an intervention is effective isn't enough to make it ethical. So it needs to be effective, but it also needs to be the least restrictive. And we need to consider reinforcement-based treatments over punishment-based ones. Many other interventions have research behind them saying that they are effective in reducing problem behavior. So saying restraints and seclusion can be effective is just not sufficient. One thing to consider is that when you attempt to restrain another person, they will likely fight back. This increases problem behavior. And aggressive and self-injurious behavior can escalate quickly. So it could end up having the opposite effect of what was intended. By McGee and Ellis in 2001, 2 boys with developmental disabilities were studied, and they had aggression and self-injurious behaviors. The function was unknown after conducting an FA. This graph, we see a comparison of their problem behavior in a play condition compared to in a restraint condition when a restraint was used for their problem behaviors. The restraints actually increased both boys. You can see an increasing trend in the restraint condition on the graph. So effective results, as Lindsay mentioned earlier, don't necessarily generalize to all clients in all situations. And knowing the function of the behavior is imperative when using restraints and seclusion. To conclude, it's best to use restraints as a last resort and to use reinforcement-based interventions before resorting to restraints.
Andrea will come back now and end the debate with her concluding comments.
The argument on whether to use restrictive methods or not is one that's been going on for many years. It has been stated throughout the literature that restraints and seclusion are indeed effective in preventing harm to individuals and others in the instances of aggression, but is it really effective? When speaking long-term, is the use of restrictive methods helping these individuals or inflicting more damage? Reasons such as not enough evidence and application of punishment over reinforcement support our position against seclusion. However, behavior analysts are posed with a difficult decision on whether to implement these methods. Most importantly, behavior analysts should ensure they follow the professional and ethical compliance code for behavior analysts, that the individuals are receiving the most effective interventions, and that no harm is being inflicted on these individuals. We recommend following these guidelines for the BACB. This will surely guide you in the future endeavors and help you navigate toward effective interventions and quality care for individuals on which you have an impact.
Here are our references for what we used during the debate. And now we will open it up for audience questions. The first question, I think Lindsay will say for us.
Yes. My question is, with the research that has shown deaths and injuries due to restraints and seclusion, how can you still justify using them?
I would say data stating deaths have been not necessarily accurate in the amount that have been stated, and with the meta-analysis by day for 2002 actually found that 53% of the deaths that were reported due to situations around seclusion and restraint actually didn't have a definitive cause. It was just cause for concern since they were in the near vicinity of those use of those procedures. And I think deaths can come from injury and malpractice of individuals, and not necessarily the restraint and seclusion procedures themselves, as well as BCBA is doing a good job of making sure that they assess the risks and oversee the training and implementation effectively of these types of procedures, since they are considered punishment procedures. And with those, we need to do the best job that we can as BCBAs in order to monitor and, if ineffective, take them out and use a different intervention as immediately as possible for the sake of the client. Next question, Andrea has for us.
How do parents know if their child is being properly restrained or secluded? For instance, would the professionals use the same procedure in the exact same way if the parent were present?
So I think that parents should be involved in understanding and implementing all of the types of things that go into a behavior intervention plan. Because as BCBAs, we need to make sure that communication for any of the treatments that are used are given to the families, all the information that is necessary for them and the client to make an informed decision if they are also the ones that need to be involved if they are able to. I think ethically and professionally, applications should have 100% treatment integrity, which isn't necessarily the case for all things in practice and application, and that's why we oversee and monitor things on a normal basis. And normally guidelines have definitive criteria for implementation, so there shouldn't be that big of a gap from treatment integrity up at 100%, and it should only be minor things, as well as parents being able to come in and maybe watch a video or something that the staff put together as that explains what they're doing as they're doing it, and they can explain how much pressure they're using. And so the parents for the first time don't see it, and it looks very bad if you're holding someone down on a mat or putting them into a room if they're kind of fighting you. It definitely can look bad or negative, but I think that making sure the parents understand and can even have visuals can help them to know exactly what they're getting into when they are signing off on these types of things, and knowing what other possibilities they could try or may not try, and weighing the benefits and the risks of using these procedures. They're fully informed when they are able to use these. And I think the last question, have you had to use restraint or seclusion in your practice, or have you used it in practice yourself? What methods did you use, and what were the circumstances surrounding its use, and would you use it again if the same situation came up in the future? And I think first we'll go to Lindsay to answer this.
So at the school that I work at, I mentioned it briefly in the debate as part of personal experience, but we have what's called our safe room or quiet room, and it is a padded wall, and it's like a little corner in our school where there's no door, there's no lock, it's just an open door. And what we do is, I had to use this with a kid the other day. He had gotten aggressive, he was in crisis, and we took the kid and we got him into the safe room. And what we did was we did block his aggression using a padded mat, but we talked to him, we coached him through it, and we made sure that he was being able to tell us some of the things he likes, like, oh, what's Blue's favorite color? What color is magenta? So things that would be able to calm him down, that took him away from the fact he was frustrated. And in the end, we calmed him down and we got him back to switch to the normal classroom. As well as I've noticed my school, some of the buses that come to us, we have kids who are in cars. We have kids who have more restrictive buckles. That way they can't unbuckle themselves during the car ride or during the bus ride. And this prevents them getting hurt, getting the drivers hurt, an accident occurring or injury occurring because some of them may become aggressive. And what I use the safe room and what I recommend them using those more restrictive buckles, yes, of course I would, just because it has protected those kids, as well as we're not technically secluding them. We're making sure they're calming down every step of the way, and it's in the least restrictive method possible. We're not. So, thank you.
So the company that I work for, I was required to complete safety training for one of my more aggressive clients. And the safety training is called QBS safety training, which emphasizes preventative measures and to use least restrictive procedures. But the client that I took the training for actually lives in a county where we're not able to touch the client at all. So I personally have never had to use any of the restraints or seclusions. But in our training, we did learn how to do one-person and two-person holds, escorting someone out of the room, and chair stability holds. We also went over the importance of documenting any incidents, big or small. So I personally haven't had to use seclusion or restraints, and I personally prefer to use de-escalation as a preventative measure.
And that concludes our debate and questions. I hope that you can use this to make an informed decision in the future for any situations that arise.